Hello, everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Payne, editor for MS Focus, and I'm joined by Dr. Augusto Miravalle, who will be talking to us about brain health. After the presentation from Dr. Miravalle, we'll open it up for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Miravalle is a board-certified neurologist who subspecializes in multiple sclerosis and related neuroimmunological disorders of the brain and spinal cord. Dr. Miravalle has been involved in both clinical and science-based research. Before joining Advanced Neurology of Colorado in Fort Collins, Colorado, Dr. Miravalle served as Associate Professor, Associate Chair of Education, and Chief of the Multiple Sclerosis Division at the University of Florida College of Medicine. He served as Chair for the National MS Society Healthcare Council in the state of Florida. He was also a member of the Rocky Mountain MS Center and faculty at the University of Colorado Department of Neurology. Dr. Miravalle was the recipient of the 2012 American Neurological Association Medical Education Fellowship Award, the 2015 American Academy of Neurology Research and Education Award, and the 2015 American Board of Psychiatry and Neurology Faculty Education Innovation Award. Dr. Miravalle enjoys sharing his love for the outdoors with his family. We are pleased to have him join us to present this important topic. Dr. Miravalle, I want to thank you for being with us, and I'll turn it over to you.
Of this program. I'm a big fan of what this organization does for providers and patients. So I'm delighted to be part of that effort as well. So today we thought to cover the topic of brain health, and that's a passion of mine, and partially also developed by collaboration with MS Foundation, which I will cover in future slides. So Chris, why don't we go to the next slide? And these are the goals for today. We will review basic principles around multiple sclerosis just to get us all, on the same page. You're very familiar with some of these, so I will make it very brief and to the point, but I want to make sure that some of these topics that are important to ground the foundation for discussions around the principles on brain health, brain reserve, and neuronal plasticity. These terms are often used when we discuss this important topic. And last but not least, also talk about MS therapies and how the use of these therapies can help us to achieve brain health. Next. So there are many definitions of brain health, and I put here some that actually resonates with me, which has to do with basically it's the optimal function of the most important organ in our body. And of course, I'm biased because I'm a neurologist and I care about the brain. But if you think about the brain controls anything that we do, controls movement, controls thinking, controls behavior. And not only that, but it's a system that is actually reciprocal, right? So not only the brain helps in controlling voluntary activity, but also a lot of the involuntary activity, feelings, environmental factors, and mood, quarantine situations will affect the brain in a similar way. So it's a system that is constantly being influenced by a lot of things that we do and we live and we experience. And those principles are important to keep in mind because the function of the brain is constantly being influenced by a lot of the things that we do. Another definition of brain health is the ability to remember, to learn, to play, to concentrate, and maintain a clear and active mind, which basically summarizes the main functions of the brain. So these are simple but easy to remember definitions. Basically, brain health is about making the most of your brain, trying to achieve that maximal brain capacity, that regardless of what stage in life you are, regardless of whether you do have MS or you don't, trying to achieve that maximal capacity is ultimately what we are trying to do when we talk about reaching brain health. Let's go to the next slide. So I will, as I mentioned before, divide this talk today into 3 sections. We first will start with a brief discussion about MS. Then we'll talk about brain reserve, and then we'll talk more about setting up goals in terms of therapies and the use of disease-modifying therapies in multiple sclerosis. So go to the next slide. So I titled these From Genes to Germs because we know that a big part of the pathophysiology of MS, meaning what causes MS and what is involved in the disease process, has to do with these environmental factors and the interplay between that and genetic factors. So we know now that MS is affecting over 1 million individuals in the US and over 4 million individuals in the world. We know that MS affects most of the individuals affected with MS will have their first symptoms early on in life, anywhere between their teens and 40 to 45 years of age. However, as you probably are aware, patients with MS can develop the disease when they're toddlers or infants. We have pediatric MS patients as well as newly diagnosed patients in their 60s. So truly is very variable. Regardless of the time of onset of symptoms, we always think that the disease itself starts around the same time, which is in early life, in the early years of life. And some patients may have symptoms earlier. Sometimes patients may have a silent phase of the disease. And truly that depends on many factors, but perhaps the easiest one to understand is depending on where those lesions are. If the lesions affecting areas that you use on a daily basis, you're going to have symptoms from that, and that may prompt an earlier diagnosis. We also know that there is a female to male race ratio that continues to increase the gap. Currently, we think that is estimated as 2.4 to 1. Like many autoimmune disorders or immune-mediated disorders, females have a higher risk of developing the disease. However, when you look at outcomes, males appears to have a slightly higher risk of, for example, spinal cord disease that usually is linked to worse clinical outcomes. We know that if we don't intervene, this disease is devastating and can affect people's quality of life, can affect neurological function, the ability to move, to walk, to work, cognitive decline. In the past, we also used to say that lifespan is decreased by 5 years. And this is one of the biggest accomplishments of the last century, that with the administration of disease-modifying therapies, now we know that that's no longer true. In patients with MS who receive disease-modifying therapies, life expectancy is the same as those without multiple sclerosis. And that's true for any of the disease-modifying therapies. It's not linked to anyone in particular. It's a very costly disease, and these numbers are very inaccurate. The reason being, it is hard to estimate the true cost of MS. But in general, we look at cost related to direct use of healthcare, but also cost directly linked to the lack of productivity, as this disease affects younger individuals. Individuals are working, and if they have to reach disability, if they have to use resources from the community to get access to care, there is an indirect cost as well that is thought to be in the billions of dollars per year to the U.S. economy. And linked to that, we know that the amount of disability that patients with MS could accumulate makes this disease the leading cause of disability in young women and the second leading cause of disability in young males, from neurological disorders in the US. So it's something that we need to take seriously, not only from an individual standpoint, but from a public health standpoint, as this disease is affecting a large part of our productive population in the US, in the world. Let's go to the next slide. So this tries to kind of summarize the interplay between different factors that are thought to be contributing to the risk of MS. One is in the middle, you see the DNA, and that's representing the genetic factors. We know that 10 to 15% of patients with MS will have a first-degree relative with multiple sclerosis. And even though the disease is not inherited, but what disease happens is that those patients will get genes from their parents, and those genes are involved in the modulation of immune responses. They will get involved also in the way our immune system responds to certain environmental factors, leading to more or less chances of developing autoimmune reactions. In the left side of the screen, you see the picture of viruses, and in particular with Epstein-Barr virus. And we know that it's been linked for actually centuries, since the disease was first recognized in 1800 by Charcot. That the thought was that there was a virus that caused this disease. And we still think, even though it's not caused by a virus, but we think that perhaps there is some sort of trigger that viral disorders could do in an already autoimmune system or environment that is more predisposed for autoimmunity, that perhaps this virus serves as the first step to trigger that autoimmunity. So again, the disease is not caused by a virus, but perhaps some sort of viral response has to be involved or could be involved in those cases. And last but not least, there are environmental factors. We know that the environment plays a role in many of our conditions in medicine. MS is one example, whether it's vitamin D deficiency, whether it's nutritional aspects, whether it's altitude, geographical areas. We know that those factors actually will increase or modulate the risk of the disease. Next. So in terms of race and ethnicity, we know that there are also some variability among groups. We know that among white, non-Hispanic individuals, Caucasian individuals, the lifetime risk of MS is about 1 in 400, and there is a lot of variability depending on geography. It seems to be lower in Hispanic, Black, and Asian populations. However, in those individuals, it might be a different clinical presentation. We always talk about a higher risk of developing spinal disease and optical spinal disease in Asian and Hispanics, particularly from South America. In the case of monozygotic twins, there is a concordance rate that is approximately 25%. So it's something that, again, speaks to the genetic component of this disease. And having a sibling with MS increases the risk of the disease by almost 40-fold. And there are recently publications show that over 200 genes have been linked to MS, and approximately we learn in anywhere between 10 to 12 genes a year that have been linked to MS. So it's something that still the story is unfolding. So interesting, you have some outbreaks, for lack of a better term. I guess that's part of our lingo nowadays of MS. And you see that there are certain pockets in the world that have all of a sudden a higher incidence of the disease. And it's kind of provocative to think about, again, the role of certain infections when you see that, to try to explain why certain areas have a higher incidence, like Colorado, for example. And some numbers appears to be faster growing in certain regions. So that's again speaks to the environmental component of this disease. Next. So this is just to dive a little bit deeper into the relationship between Epstein-Barr virus and MS. And these are certain studies that looked at the exposure to this virus, particularly early in life, and how not only the infection itself, but when that infection happens, how that could increase the risk of MS. And that has to do with the fact that if a virus is going to confuse the immune system in a way that could lead to autoimmunity, and that's kind of like a thought. The virus itself is so similar to myelin that when the immune cells recognize the virus and they develop what we call memory cells, those cells now became trained not only to respond to the virus, but also they might respond to your own myelin. And that's something we call molecular mimicry, in which the immune cells are not able to discern between self-antigens and foreign antigens. So keeping that in mind, then it truly depends on how experienced your immune system is when it's exposed to these viruses. And in a sense, the age at exposure appears to play a role in this as well. And like with any infection, socioeconomic status appears to also play a role in the risk of developing infections, right? So if you are in a place in which there is better sanitation and better access to healthcare, the thought is that certain infections like Epstein-Barr, the incidence will be lower early on in life. Let's go to the next one. And here you see the cartoon of perhaps the largest study to date looking at this relationship, which came from the VA database. And you see that there were 11 patients that developed a symptomatic Epstein-Barr virus infection. And you can see in this graph when they turn from yellow to green, and within months, they developed multiple sclerosis. And most of those patients were adults, and that means that they were not exposed to the virus early on in life, and they became exposed to the virus later and subsequently developed MS. So this is, again, very provocative to think about this temporal relationship, not suggesting that Epstein-Barr virus causes MS, but again, going back to the fact that perhaps it just confuses the immune system, serves as a trigger that will subsequently lead to kind of like a dysfunctional autoimmune response. And I see that there are some questions coming in. I will address those as we move on. So let's see. Joe is making comments about, yes, true, the insurance payments, when you count those things, the cost of MS is significantly higher than what I'm showing in the slide. So there's a lot of variability when you look at cost. And then there's a question about many known genes. Does MS maybe many different diseases? No, that's a great question. So MS is one disease, and what happens is that disease has a lot of variability in patient to patient. But the disease itself, when you talk about an entity like multiple sclerosis, you pay attention to, the clinical presentation, what we call the phenotype of the disease. We look at the characteristics of the MRI findings, and you can see some trends. And that's why we have diagnostic criteria that allow us to make that diagnosis based on those factors. However, there's a lot of variability from patient to patient, and that's something that I personally take into account. And one of my favorite phrases is, every patient is different, right? And when we design therapies for our patients, we need to keep that in mind. Centralized, patient-centered care is important. There is a question about tumefactive MS, and all it is the disease is the same disease. What happened is that the lesions appear to have more of a tumor-like presentation. So those are larger lesions with a lot of edema, a lot of swelling. and often at presentation can mimic tumors, and that's the name, tumefactive MS. The truth is that those patients actually have a similar course of the disease than patients without tumefactive presentations. So we often use highly effective therapies early on, no matter what, but to those patients too. But the truth is that it's still multiple sclerosis. So let's move on to the next slide. So talking about genes, this keeps changing by the minute, but we know that there is an association with the HLA-DRB1 that has been present in up to 30% of individuals in certain regions. We talked about the heterozygous versus the homozygous risk, and appears to be, again, a 3 to 6-fold increase. And as we talked before, there are what we call epigenetic factors, meaning environmental factors and host type factors, but also gene-to-gene factors. So it's, in a sense, it's not just the presence of a single gene is going to cause a disease, but when you have multiple genes, kind of like exponentially increase that risk of developing multiple sclerosis. So let's go to the next slide. Geography also plays an important role, and we know that there are pockets in the world, and even within the US, for example, there are certain areas that have a higher incidence and prevalence of multiple sclerosis. We always talk about, around Michigan, Chicago area, in the Northeast region, in Massachusetts and Maine, and certainly Colorado. Those are areas with high incidence. But as you know, in times, not in times of pandemic, but when people could travel, there is a lot of migration that happens. So it's also interesting to see what happened with these numbers as people move. And globally, we estimate that the prevalence of MS is approximately 30 per 100,000. But that can range anywhere between 0.1 in places like, for example, Africa, that has an extremely low prevalence of MS, to 140, like in certain parts of Europe, particularly in Scandinavian countries, and certain parts of the US as well. So it is a lot of variability. And when these individuals travel from place to place, they carry that risk of MS, and of course they're going to change the prevalence on the places that they move to. But most importantly, when somebody travels from a place of high incidence of MS or high risk of MS without having the disease to a place of low incidence, that also can change the overall lifetime risk of MS. And the studies that showed perhaps the most interesting numbers on that suggest that the first 15 years of life appears to be that time that truly gets influenced by where you grow up. And if you grow up in a place of low incidence of MS, like, for example, Israel, and you move to a place of high incidence of MS, like Boston, and that transition happens before the age of 15, those individuals will carry the same risk of MS as those who were born in Boston. So it's almost like you acquire the risk of the place you move to. And that's particularly true if that move happens before the age of 15. Again, suggesting that there is an early phenomenon that happens, perhaps exposure to some environmental factors that are independent of your genes that also modulate that risk. Let's go to the next. So vitamin D, as you're aware, since 2015 or even earlier, we know that it's a factor. And vitamin D deficiency has been linked to a higher risk of developing MS, as well as perhaps worse clinical outcomes. So we do recommend to monitor the levels of vitamin D, and if deficient, to supplement. Vitamin D3 is what we prefer to supplement with oral therapies. And usually, at least here in Colorado, most patients require anywhere between 3,000 to 5,000 units daily to truly get to normal levels. Let's go to the next slide. And here you can see that when you look at the map of vitamin D deficiency in the world, almost mimics the map of MS. So these areas that are here in red, those are places that have the highest deficiency of vitamin D, and interestingly also have the highest incidence of MS. And the same is true in the other way. So places in blue in which vitamin D it's for the most part normal in those individuals, they have a lower incidence of multiple sclerosis. So this is very actually interesting to see almost a one-to-one relationship between the incidence or risk of MS and vitamin D. But as I mentioned before, it's not just one factor. Let's move on. And here is one of the many pieces of research that actually helped us understand the relationship between vitamin D and the immune system. And you can see that when you look at different levels of vitamin D, at different levels, this vitamin is going to influence different type of cells. And once you get to the higher levels, as you can see in the graph, there's a significant impact on decreasing the activation of certain pro-inflammatory cells. In this case, the T helper 1 and T helper 17. We know that those are the cells that are involved in a big part of the inflammation that happens in multiple sclerosis. Let's go to the next slide. So salt is a big one, and the more we know about sodium, the more we realize that plays a role in MS, and also in overall brain health. Going back to the topic of today, recent studies presented in the last version of ECTRIMS shows that actually there is an accumulation of sodium in the brain in people who just eat salt. So we recommend, we follow the guidelines from the World Health Organization that recommends no more than 2 grams of salt a day. And when you look at what we eat, most processed foods will have salt in it. And 2 grams is pretty much a third of a teaspoon. So when you look at that, pretty much you realize that you should not be adding salt to your diet at all. It's always better to just use other ways to bring some flavor to your food. But here there are studies done in animals, in mice, also in human studies that show that increased salt concentration increase inflammation. And again, these cells, the T helper 17, which are pro-inflammatory in MS, get significantly stimulated with just a simple administration of salt to certain animals. Let's move on. So this is, again, a study done in humans and looking just particularly in MS patients. And they looked at levels of sodium, not only by measuring how much they ate, but also how much they eliminated sodium in the urine. And they compare that to clinical and MRI outcomes, and they saw a nice relationship between the higher levels of sodium intake with an increased rate of relapse rate, as well as an increased rate of new lesions on the MRI, regardless of what medications they were taking. And that's why we always recommend to not exceed the 2 grams a day of sodium. Of course, like many things in medicine, we know that smoking cigarettes is bad for you, and MS is not an exception for that. Hopefully by now you're familiar with this data, but basically we need to advocate for smoking cessation when possible. Again, there is disruption of the blood-brain barrier, there is increased inflammation, there is a direct effect on demyelination. There is also a direct effect on remyelination. I mean, we are talking today about brain health, and we know that the brain can repair itself. We just need to allow that to happen by stopping inflammation and by promoting healthy brain activities. Well, if you smoke, you pretty much as not allowing your brain to repair. So that should be something that has to be discussed at any visits. If you're smoking, we need to help you with resources to stop smoking. Let's go to the next slide. So this cartoon tries to, and you can actually scroll all the way so we get the full picture here, shows kind of like the dynamic of the disease itself. So we know that early on, at onset of the disease, that inflammatory response is most active. And that has to do with many factors, perhaps the fact that the immune cells are very naive, new, very inflammatory. They like to do what they think is right. In this case, they are doing the wrong thing, even though they are trying to help you, but they're going after your brain cells. So that inflammatory response is maximal early on in life. And as we get older, over time, you can see that pink cartoon goes down. That means that the immune cells also are becoming less active. That's something we call immune senescence. And that's why you see, for example, in cases of COVID-19, that those individuals who are older are the ones that they can't fight the infection very well, and they have complications. That's a clear example of immune senescence. Your immune cells, as you get older, are not as active. So for MS is something that we also keep in mind, because perhaps as you get into your 60s and 70s, we don't have to use such highly effective therapies that could potentially increase the risk of infections. So we have to look at age, we have to look at the stage of your MS when deciding these therapies. Also, it's true that early on in life, that's where you have the maximal chances of repair and regeneration. And that's something that our brain does every time. So that's why early on is when we advocate to try to be as proactive and as aggressive as we can to stop these immune reactions and immune interaction. If we don't do that, the phase of the disease that we call progressive MS, it's also known as degeneration. That's when things like brain atrophy plays a role. That's like the brain starts to get smaller, and axonal damage, or those wires, those copper wires in the brain, they actually start to degenerate. And that's when we see that progression starts. And when these two lines, which here is this red circle, kind of cross, is when we say that a patient went from a relapsing remitting MS to a secondary progressive phase of the disease. And then you can see cartoons underneath showing it's how these immune cells here in blue, those blue dots that you see there, are entering the brain through that blood vessel. And through that, actually, they just go to the brain and cause demyelination. And in the section B, you can see a myelin stain that normally should stain all blue. And in that MS black, there is no blue, meaning there is no myelin. And in the picture in C, you can see that dark line, that's an axon, actually. And it's an axon that is actually getting transected in the middle. And if you imagine a tension cord, an elastic band that you're about to cut, there is going to be a retraction valve on either side of that transection. And those are the bumps that you see there. The core is about to break. And axonal damage happens in MS. And that's something that we try to prevent. Let's go to the next slide. So how do we know that? Well, one way we do that is by doing MRIs. And here you have multiple pictures of MRIs. You're probably familiar with these. You had MRIs yourself. And you can see that the lesions look in certain characteristics. They are these ovoid-shaped longitudinal lesions in the brain. And if you look at E, the section E, you can see that the square is showing a lesion that has a dark line in the middle, and that's something that we call the central vein sign. That means that in the middle of that lesion there is a vein, and very likely that vein is where the immune cells came and caused the lesion around the vein. So Celia is asking, so what does the chart look like when the first flare-up is at 55-year-old? So very good question. So we, as we mentioned before, the disease itself starts pretty likely early on in life. The fact that the first relapse occurred later on in life perhaps means that throughout these years, those lesions have been probably asymptomatic. But the immune senescence depends on age. It does not depend on when the disease started. So that's something that people with or without MS go through. So that's why we see that the risk of infections increases after our 60s and 70s, regardless of when MS started. So the chart looks the same. It's just what happens is that the disease itself shifted, and the first symptoms started later, but very likely the disease itself, the lesions and the atrophy started many years prior to that first relapse. That's a very good question. Let's go to the next slide. So here, just to show you that different techniques on MRI shows different lesions, and that's why we always try to advocate to try to do the MRIs in the best possible place. Look at the strength of the magnet is measured by Tesla units. So the 3 Tesla is the best that we have commercially available. And so always try to do it in the best scan that you can. If you can't, at least stay with the same one, because sometimes what happens is if you change different scanners, different MRIs, you go from one with poor quality to one with good quality. All of a sudden, the last MRI shows 10 more lesions, but it's not that you developed 10 more lesions, it's that you always had those and you couldn't see them in the previous one. So it's always good to stay on this with the same MRI as you go through. So yeah, no, we don't have treatments to remove salts. Joe asked a question, can we remove salt from the body? No, not for this circumstance. So the recommendation is to not eat or minimize the use of salt in your diet. But so there is nothing, no chelation therapy, so we recommend for MS. So that concludes the first section of the presentation, which is a very brief overview on MS. I wanted to emphasize a few aspects of the disease that hopefully lay the groundbreak for the next section, which is brain reserve. That's why we are talking here today, brain health and brain reserve. And that's the question that I would like you to start thinking about, which is, can I build my brain reserve? Can I improve my brain capacity? Can I help my brain to be healthier? And hopefully at the end of the talk, you realize that the answer is yes. So Chris, let's go to the next slide. So brain reserve, this is a formal definition, is the ability to tolerate the age-related changes and disease-related pathology in the brain without developing clear symptoms. So look at your brain reserve, that buffer, the ability of the brain to compensate for anything that could be happening to you, anywhere from aging to MS. If you want to compare your brain to your bank accounts, your brain reserve is your savings, right? So allows to help the check-ins, which is what you're using every day, to have some sort of buffer in case something happens in the check-ins and something drops there, you can transfer that from savings to check-ins, and that way you can help that. So the brain reserve is your buffer, the ability to compensate for things. And, you know, we are born with a lot of brain reserve. And as we go through life, we can enhance that brain reserve, but we can also lose brain reserve. And that's why, you know, it's a balance between, when you look at brain health in MS, you need to stop doing the things that are harmful to your brain reserve: smoking, salt, eating trans fats, and we'll talk about that. Plus, you have inflammation. That's why you need to stop inflammation with medications. And also you need to do things that will enhance brain reserve. And if you can do both, that's when you get the best results. The other thing that I also like to remind you is that the brain is an extremely plastic organ. And with that, I mean, the brain can change itself. The brain can adapt very quickly. And that adaptation of the brain is what we call plasticity. And that depends on genetic factors, but also, most importantly, depends on what you do. The brain will respond to what you do. If you want the brain to be healthier, you have to do healthy activities. If you want the brain to be better at some task, you need to train the brain. So let's go to the next slide, and I have more concrete ways to explain that. So in a sense, if you remember the graph that we talked before about, inflammation, immune senescence and stuff, you can add to that graph this, which is the brain reserve as we age decreases. And perhaps the most concrete way to measure that is to look at brain atrophy or shrinkage of the brain. And without MS, an adult individual will lose approximately 0.2% of brain reserve a year, or brain atrophy. So every year we lose approximately 0.2%. With MS, without therapies, that brain atrophy is approximately 1 to 1.5% a year. And that's why it's key that we use therapies and we do things to try to bring that brain atrophy down to healthy controls. And I'm going to pause here, and I'm going to share with you the story that is very recent. It's a patient that I just saw this week, and she's 47. She had MS for 10 years. And when I first met her last year, she was about to start using a cane because she could not walk because of weakness on the right leg. And she also was considering applying for Social Security disability and stop working because she felt that she could not concentrate. So we did an MRI then, and the patient had approximately 40 lesions, and the brain volume at the time was a year ago, was 1,200 cubic centimeters. And that is approximately at the 10th percentile of her age. So when we met last year, I talked to her about all of these factors. We started a highly effective therapy for her MS, but most importantly, she started exercising. She ate healthy. She stopped drinking alcohol. She stopped using salt. Pretty much everything that we are talking today, she did. And she was very diligent with that. So we did an MRI now. First of all, she came to the office without a cane. She was walking, still weak on the right leg, but she was walking. She still works. And we did an MRI, and her MRI now was 1,300 cubic centimeters. So not only didn't shrink, but actually was larger. And that's perhaps the best story that I have in years to tell you, because that's a very concrete way to show that, yes, you can rebuild brain, you can rebuild plasticity, you can actually help to stop MS by doing all of these things. And it's not just one therapy. It's good therapy plus eat healthy, exercise, change your lifestyle and become healthier. And she's 47, right? So we always say, well, once you're after your 30s, that's very difficult, but she managed to do that. So that was a great story. So let's go to the next slide. So perhaps you're familiar with this. This is a model that is trying to exemplify in a graphic way, in a visual way, this very complex concept of brain reserve. And that was developed by Steven Krieger, is known as a topographical model of MS, and tries to resemble the brain volume and brain reserve as water in a swimming pool. And what the model proposes is that different areas of the brain have different brain capacities. And that's why you see that the swimming pool has 3 sections. A section that is a shallow end of the pool, that represents your spinal cord, your optic nerve. And then you have a middle portion of the pool, and then you have a deep end of the pool. And of course, as you can imagine, each section will have different water levels, different capacities, different brain reserve. So if you're in the deeper part of the pool, you have a lot of brain reserve. And that's why lesions here represented as these white bumps. Lesions will cause symptoms if they cross the water level. And that means that that brain reserve is no longer able to mask the presence of these lesions. So not only the size of the lesion matter, but also where the lesion is important. So if you have, let's say, a 5 centimeter lesion in the deep side of the pool, very likely that lesion is not going to cause symptoms because you have a lot of brain reserve there. But if you have a 3-centimeter lesion in the shallow part of the pool, very likely it's going to cause symptoms because you have less brain reserve. And that explains why not all the lesions cause symptoms. That explains why somebody could have MS for 20 years and never had symptoms, because perhaps those lesions were affecting the deep part of the pool, which is the upper part of the brain, the stereo hemispheres. So I think this is a nice way to explain that. But also this model explains what happens as we start to lose water in the pool, right? So water, again, represents brain reserve, and brain reserve is brain volume. So as we get older and we start to lose brain volume, you start to lose water in the pool. And that could lead to the fact that some of the lesions that were initially masked or compensated by this water level, as you lose water, all of a sudden these lesions are no longer masked. And that explains why patients over time, particularly as they get older and the brain shrinks, sometimes they start feeling worse, even though the number of lesions is the same. And that's why preserving brain volume in this model, equivalent to bringing more water to your pool, is critical, is very important. And that's why we are talking today. What can we do to increase that water level? And like the patient I present to you, what can we do to stop brain atrophy, and perhaps even better, to improve brain volume over time? Let's go to the next slide. So a few things that actually we are learning when we use advanced imaging in MS is, we always concentrate on lesions and relapses because it's kind of like the tip of the iceberg. Those are things that we can measure, we can see, patients feel. But we know that MS, the inflammation in MS and changes in the brain in MS happens at all times, even in between relapses. Both a negative plasticity, but also a positive plasticity. Some benefits to the brain happens even in between relapses. And the ability of the brain to compensate and to reorganize itself is different at different stages in your life, and it's also different in between people. And that's one of the reasons why you see that for some individuals, MS is devastating early on in life, and patients have multiple lesions and they're in wheelchairs very early on. And some patients with MS, you see them in their 70s and you can barely tell they have MS. So that there are certain factors that actually explain this is one of those, which is the ability of the brain to reorganize and repair. And some studies looking at these principles in other disease states, like Alzheimer's, for example, taught us a lot. And it seems like we can modulate that water level in the pool, that brain plasticity, by, not surprisingly, using the brain. And individuals who have higher level of education, that they went to college, individuals that speaks different languages, they play instruments, they play sports, they're physically active, those individuals actually have more brain reserve, better brain capacity. And it's never too late, right, to start doing that. So you don't have to just think, okay, my time is gone. No, if you're 60, you can still change the way you live your life to try to keep that brain as active as you can. Let's go to the next slide. So we also know that inflammation is bad for this, and that's why a key portion of brain health is to stop inflammation. And we do that with nutritional efforts, but also with medications, and we'll briefly talk about that. Let's go to the next slide. I think I need to become a little bit faster so I can cover everything. We know that when we move, we increase the ability of the cortex to repair and remyelinate. And that was seen with what we call functional MRIs. If you go to the next slide, I'm going to show a picture about that. So you can see here an individual in the top line is a healthy control. And this individual was just simply moving a finger, what we call finger tapping, inside an MRI. And you can see that that person activates those areas of the brain that you can see here in red and yellow. So just by simply moving a finger, you're using those areas. Then they did the same experiment in someone with multiple sclerosis at the same age. And what you can see here is that the MS patient, by simply moving a finger, activated a lot of brain. And why is that? Well, the reason for it is because of having these lesions, having MS, you have to use a lot of brain to accomplish the same function, because the system is not being effective, is not being efficient with the effort that you want to do to accomplish your goals. And that's why you see that an MS patient, just to do the same function, has to use more brain. Well, this explains many things. Perhaps explains the most common problem in MS, which is fatigue. And you're going to understand that if you have to constantly be using 20-30% of your brain to do the same things as healthy controls, it's going to come a point in which your brain is going to be tired. And that's why you have fatigue. I just move on to the next slide. And the same is true with cognitive tasks, right? So we talked about finger tapping, but when we do the same experiment in patients on functional MRIs and we ask them to do a cognitive task, whether it's memory, attention, you see the same things. Let's go to the next slide. This is what I want to show, which is the concept of training improves function. And you can see again the same type of approach. You have the controls on the top, and this was with the cognitive task, and then you have the MS patients and the bottom. And you can see that, like with the finger tapping, MS patients are using more brain to do the same task. But then they did the same experiment. If you click again, Chris, after treatment, in this case with interference, and after cortical or physical training. And you can see that the same patient with MS that early on had more cortical activation, with training and with anti-inflammatory therapies, brought that cortical activation back to baseline levels for healthy controls. So I think this is perhaps the most concrete example that we have to support the fact that when you do physical activity, when you do training, when you do physical therapy, you are actually making that system more efficient. And that's one of the reasons why, if you have fatigue, your doctor may tell you, well, you need to exercise, even though it sounds counterproductive. But at the end of the day, if you train your body to do the things you want to do, your system becomes more efficient, and overall you will have less fatigue. Let's go to the next slide. And this is another example for the same principle. In this case, it's a patient with a stroke. And you can see that right after the stroke, in which you can see in the top, half of that hemisphere is gone because of that massive stroke. The patient was activating many areas, including on the other side of the brain. And after training, after physical therapy, you can see that the number of neurons activated was significantly smaller. So this principle of rehabilitation, of cortical plasticity, reorganization of the brain, is not just true for MS, it's true for many neurological disorders, including strokes. Let's go to the next slide. So we talked about the negative effects of smoking, and smoking, as you can imagine, also has negative effects in brain atrophy, as well as remyelination. Let's move on to the next slide, Chris. What about diet? So as you probably know, I'm a big proponent of healthy diet. And the reason being, everything we do, including what we eat, affects the brain. So perhaps the one diet that has the strongest clinical evidence is what we call the Mediterranean diet in MS. And there are many diets with names out there that you will read. And some of those have some degree of evidence. So perhaps this one has the strongest. And here you have an example of what that Mediterranean diet means in terms of what foods are allowed or recommended. But on this PET scan, you can see that an individual with following a Mediterranean diet had more activation of the brain than an individual having what we call the Western diet, which is the typical diet in here in the US, have less activation of the brain. And this scan is different to the one that I showed you before. In this case, more activation is better. So you can see that it just a single factor like dietary changes will significantly impact on how active that brain is. And as I mentioned before, in this case, you want this brain to be more active. Let's move on to the next slide. Music is important. We are learning that, and there is an interesting growing body of literature that is suggesting that music is food for the brain, particularly if you perform, but actually listening to music too. For example, musicians have a larger corpus callosum, which is that middle section of the brain that connects both hemispheres. And also music has a positive impact on depression and anxiety. Let's move on. And just to finish with the third section, I thought to just briefly mention something about expectation of therapies, which has to do with setting up the goals for these therapies. Let's go to the next slide, Chris. So we can skip that. This is what we already talked before, which is early on we have more relapses, more inflammation, and that's the time for the window for therapy early on. But it's never too late, right? But early on is when you have the biggest impact on that anti-inflammation that you get with the medications. So in terms of symptoms, early on we see those relapses, but relapses can happen at any point, but the majority of the relapses happen early on in someone's life. And then as the disease progresses, as you get older, you have more of the progressive disease of type symptoms, which comes the fatigue, the cognitive decline, the difficulty ambulating, memory, and different things. On this graph, you can see that the incidence of symptoms depends also on the stage of your disease. So in red is early on relapsing remitting, and in blue you have the secondary progressive. So you can see that there is more walking difficulty, more cognitive fatigue, more of those symptoms as you get older, as the disease gets older as well. Let's go to the next slide. There are certain factors that may impact the prognosis, and here you have good and bad prognostic factors. As I mentioned before, certain races, including African American and Hispanics, have a worse prognostic factor. Older age at presentation is one of those that is also a poor prognostic factor, and that may have to do with you kind of lost the early phase of the disease, the chance, the window to affect that inflammatory disease. Gender, males in the case, also has a worse prognostic factor. Smokers, having certain types of relapses had to do with location again, may had to do with worse prognostic factors like relapses that involve weakness or balance problems or multiple symptoms at once. Those are bad relapses. And also how much of a recovery you get from a relapse. A complete recovery usually brings more of a better outcomes than an incomplete recovery. Let's go to the next slide. So the market for therapies is crowded, as you can probably see in this slide. And we have, which is good news, we have many options to choose from. And this is not the purpose of today's talk to go over all of those options. But to the point that I was trying to make today, the ideal option is the one that works for you, and every patient is different. So the process of selecting therapies has to be individualized to a particular patient's need. And actually, as patients go through life with this disease, their needs are different and their expectations may be different. And also the risk for infections is different. So that assessment should be done in every visit, whether that's the right therapy for you. Let's go to the next slide. So there are certain factors that I always try to remind patients, and it's always to keep this chart in mind when you're talking to your neurologist, which, there are certain factors that are patient-related. There are certain factors that are directly related to the disease itself and also to the medication. So we keep all of those in mind, and it's always helpful when patients are clear in terms of what is your lifestyle, what do you prefer? Are you okay with an oral therapy, or you prefer an injection, or you prefer an infusion? So those things are important. Pregnancy planning is important too. So those are important factors to keep in mind when you're having that conversation with your neurologist. Let's move on. So this is the goal that perhaps most neurologists and patients are familiar with, which is this concept of NEDA, or no evidence of disease activity, which pretty much is the ultimate goal, right? So it means no relapses, no disability progression, and no activity on MRI. And that's a great goal to have. Sometimes it's possible, sometimes it's not, but that's usually what we try to accomplish. But as you can see here, this goal does not says anything about symptoms. That's not says anything about, if you start this medication, your fatigue is going to improve or your quality of life is going to be better. It just simply narrows down that the goals for these medications, what we call disease-modifying therapies, simply is to affect the disease from this very pragmatic point of view: relapses, disability progression, and lesions. But it's often disconcerting for patients that all of a sudden they start a medication and they feel, well, wait a minute, but my fatigue didn't improve. Well, that was not a goal for that therapy, right? That's everything else we do might improve your fatigue, like exercise and sleep and things like that, but not the medication itself. Let's move on to the next slide. So there are different ways to compare therapies, and this exercise can get tricky because these studies were done at different times with different goals and different design. But in general, we have therapies that have more of a higher efficacy. That's for, in general, those monoclonal antibodies, natalizumab, ocrelizumab, alemtuzumab. Of course, we have medications like rituximab, for example, that is not approved, but is commonly used. Then we have the oral therapies that have some sort of like a middle in terms of efficacy of the range. Medications like daclizumab that is no longer available but shows some efficacy in the past. But now we have cladribine, that is a medication that is only used 2 months per year for 2 years. So there are different options that we have that, again, the conversation should be individualized to a particular patient. Let's move on to the next slide. This just to show that time is brain. And this is a study that looked at when not only the efficacy of the drug, but the efficacy related to when do we start these medications. And the message from this study is that the earlier you start, the better it gets. So I realize it's 3 o'clock already, so I don't want to go over the hour. And I think I covered the most important aspects. Chris, if you can scroll all the way to the last slide, which should not be far from now. Just keep going. There's one more, I believe. Here you go. So I just want to mention that we do have what we call a brain health program that we offer to our patients in Fort Collins in Colorado that is supported by the MS Foundation. And through that program, we pretty much cover in depth of these principles of brain health. It's a 6-week program. Now with COVID-19, we had to move to Zoom meetings, so we are offering this also remotely. So if this is something that is of interest to any of you, this is still available. We are continue to use these platforms to educate patients. And in these 6 weeks, we cover pretty much most aspects of brain health with more of a practical way to include these principles in your day-to-day life. So this is a phone number in case you want to sign up for the program. And with that, I'm going to conclude here. I don't know if we still have some minutes for questions. I see that there are some questions here about CCSBI, which is this theory that certain flow on the veins in the brain might affect individuals to develop MS. No, that model did not prove any significant evidence that is real, and that was perhaps some sort of like a false positive results in the early studies. So yes, the brain health program is still available. We just activated that. We of course had to put it on pause with COVID-19, but now it's back. It's available. We will be doing Zoom meetings. The next program starts actually soon. In a week or two, we will be doing newly diagnosed patients for that program. But then moving forward, we are hoping to continue this. And actually, depending on how that Zoom meeting goes, we might be able to continue to offer that even after the pandemic. So I see a lot of friendly faces and familiar faces. So thank you for joining us. And to sign up for the program, if Chris can put the last slide back again, that was Kathy's phone number. I can actually also tell you now, it's 919-414-3347. And you can sign up for the program. And then, again, we can hopefully continue over Zoom meetings. And someday, hopefully, we can get together again. Personally, we might do a social event to that. So I'm going to type it here on the messages so everyone has the number.
Thank you, Dr. Miravalle. Chris, unfortunately, just texted me that he had a computer crash. He is trying to reconnect right now. So if you could give out that number in the chat, we would appreciate that.
Absolutely. Yeah, I just typed it in my comments. It's 919-414-3347. And I can see Kathy is part of the call as well. So we'll be happy to include your name into the program. We were planning also to continue to do this type of meetings with MS Foundation. So we do everything we can. As I said before, there is a lot of evidence that it's never too late. So there's always something we can do to help your brain health.
All right. Well, that is the time that we have for today. I want to thank everyone for joining us. As Dr. Miravalle said, we will definitely be continuing to work together for more programs like this. So stay tuned to the Multiple Sclerosis Foundation on Facebook, Twitter, Instagram, or our website, msfocus.org, to learn about upcoming programs. And I want to say thank you to everyone for joining us, for your questions and participation, and most especially to Dr. Miravalle for this incredible presentation. Thank you so much, Doctor.
Thank you, and please stay safe.
All right. Have a good evening, everyone. Keep safe and healthy out there.